next professor who will educate us is Dr. Randa Badawi, Professor of Anesthesia. And you are going to educate us on heparin-induced thrombocytopenia, also known as HIT. Thank you, Professor.
Before we start, we have a surprise for Professor Randa Badawi. So one of your excellent colleagues want to say hello to you.
Hi, Randudi, how are you? I miss you so much, lovely. Hi, Habibti.
Thank you very much.
Nice to see you and to hear you again.
Thank you very much.
Miss you. Come back soon.
Thank you very much, Prof. Sahar Marzouk is here us to honor us today.
Yeah.
And thank you very much. Welcome, Professor.
If you excuse me, Dr. Saad, I want to add some points. Okay. Sorry to all because I wasn't available at the beginning of this course, but I would like to thank so much Dr. Ansari for his valuable, illustrative, informative lectures I used to listen because I'm so interested in critical care. So thank you so much, Dr. Ansari, and thank you to Dr. Makharita also, though pain is not my interest, but I can know that it is very interesting lectures he used to give every time. Also, Dr. Saad, really what you are doing is very, very, very precious courses because all the instructors and the lecturers are highly educated and of high faculties. So thank you so much for this effort and keep on and waiting also to hear a lot of lectures from your colleagues. Thank you.
Thank you, Prof. Sahar. Thank you for coming tonight and all the best, Prof. Randa. It's all yours now.
First of all, I'd like to say good evening to everyone. Really, I'm honored to be with you today. And I'd like to thank Dr. Saad Al-Mahdi and all the organizer committee for their great effort and hard work. Today, I'm going to discuss a very important subject for all the anesthetists, especially those working in the ICU. My topic is heparin-induced thrombocytopenia, and it's related to the nowadays events, COVID, since part of its treatment concern anticoagulants. So I found it's perfect to discuss these items. By this lecture, I'll discuss what's meant by HIT, its types, pathophysiology, risk factors for its development, clinical presentation, and lastly, treatment. I'm going to start with a scenario, and if every one of you try to pick up the correct answer and write it down, and in the end of the lecture, we will discuss it and you can see how much you know about anticoagulants and this subject. My scenario is a 62 years old male with a history of diabetes mellitus, hypertension, coronary heart disease, is admitted to hospital for unstable angina. He was recently diagnosed with HIT type 2, as now scheduled for 3-vessel cabbage. The suitable agent for intraoperative anticoagulation would be heparin, clopidogrel, ergotamine, or fondaparinol. Think of it, and we will discuss it in the end of the lecture. I'd like to give a brief, quick review or physiology of coagulation. Coagulation process aims for hemostasis. It starts after vessel injury by vascular injury by vasoconstriction of the vessel wall. This is mediated by thromboxane A2. Then activation of the platelets through its binding to subcollagen endothelium. The activated platelets release its mediators from its platelet granules, which amplify further platelet aggregation and adhesion. This is called a step of platelet activation aggregation. Then platelets share with coagulation factors, ending by the formation of the clot. The main component of the clot is thrombin. As we will see in details, the coagulation cascade is divided into, for simplicity for sure, into intrinsic pathway and extrinsic pathway. By intrinsic pathway, we mean that activation could be from inside the body or within the blood. And this pathway can occur both in vivo and vitro. While the extrinsic pathway, the stimulus for its occurrence is the release of tissue factor, so it's only a vivo process. For the intrinsic pathway, it begins with activation of factor 12. It can be, the stimulus for its activation is negative charge through exposure to subendothelial collagen in vivo or exposure to negative charge of a glass in the test tube in vitro. This is how it will start the cascade. Factor 12, it will be activated into 12. Then active 12 will activate factor 11 into active 11. Active 11 will stimulate factor 9 into active 9. Then factor 9 through the activated factor 8 will activate this part, which is the common pathway. This is the intrinsic pathway. The extrinsic pathway starts by tissue trauma, which releases thromboplastin, it's tissue factor, and it's number 3 of the anticoagulants. Factor 3 activates factor 7 into active 7. Active 7 acts on the factor 10. This is the common pathway. So the intrinsic pathway and extrinsic pathway all together ends on the common pathway. The common pathway starts with activation of factor 10 into active 10 through in the presence of active factor 8, the presence of factor 5, presence of calcium, and presence of platelets. So is the link between the coagulation cascade and platelet plug or platelet activation. Then activated factor 10 will stimulate prothrombin. This is factor 2 into active factor 2. Thrombin activates fibrinogen, which is factor 1, into fibrin monomer. Then thrombin activated factor 2, which is thrombin, activates factor 13, which changes the fibrin monomer into polymer by the action of factor 13. Okay. Let's concentrate, please, with the action of thrombin. It's the main stem or backbone of coagulation is the thrombin. Why? Here's its action. Number 1, it amplifies what's before and it activates what's after. So it activates fibrinogen into fibrin. This is number 1. Then it activates factor 13. This is number 2. In the meantime, it activates factor 5 into active. Factor 5 will be activated into active 5, and active 5, it will stimulate the thrombin formation. So the cycle will perpetuate and amplify. So it's called an amplification step action of thrombin. Also, thrombin activates factor 8, which acts on factor 9 to activate factor 10. Here's the action of coagulation for forming the clot. In the meanwhile, I don't want the clot to spread everywhere. So in the meantime, the fibrinolytic system will take action. So the one who started the problem, it will end it. So thrombin will activate what's called thrombomodulin. Thrombomodulin is the complex which binds to thrombin. So after being a very potent coagulating factor, thrombin, when it combines to thrombomodulin, it modulates its action, it becomes ineffective. This complex, TT complex, thrombomodulin complex, will activate protein C, which is a natural anticoagulant in our body. And this complex, thrombomodulin complex, after activating the protein C, will inhibit both factor 5 and 8, which were part of the stimulation in the cascade. So by this way, the coagulation process is not perpetuating forever. It's limited to the site of the trauma, while other activated clot factors will get, the body will get rid from it by this mechanism, by limiting further propagation of the process. And in the meantime, the excess activated clotting factor will be sent into the liver to inactivate it. So to know why I said the coagulation cascade, to imagine where the anticoagulant works and what are the investigations we should ask properly when we face a patient taking anticoagulant drugs. For the intrinsic pathway, we monitor by activated partial thromboplastin time. For the extrinsic pathway, we monitor by PT, prothrombin time, and INR, which is the patient ratio divided by the normal value. This is for how to check, how to choose the proper investigations whenever you are going to assess a patient. Then let's put the action on the graph. Our subject is heparin-induced thrombocytopenia. So heparin acts through what's called antithrombin trio. We discussed it a few minutes ago. So it acts mainly on activated factor 10 and activated factor 2, thrombin. From its name, antithrombin, definitely it will affect the thrombin. However, there is a great difference between the action of unfractionated heparin and low molecular weight heparin. Unfractionated heparin inhibits the activated factor 10, while the low molecular weight heparin, they activate factor 10 and cannot suppress the thrombin. And we will discuss why few minutes later. This is the site of action of heparin. The new drugs of the new oral anticoagulants are classified into drugs which has an anti-factor 10 activity and antithrombin drugs. So this is the cascade, and you can imagine where the anticoagulants work. Here in the antithrombin, herodine and liporidine are examples for the direct antithrombin. Why the low molecular weight heparin cannot suppress properly thrombin? As you know, the heparin molecule is formed of many amino acids. In the unfractionated, the length is very tall, while in the low molecular weight, the length is short. To block the activated thrombin, the heparin molecule should attach to both the antithrombin and the activated thrombin. So it should be of a long chain. So unfractionated heparin is formed of a long chain, so it will inhibit. On the other hand, the low molecular weight heparin, the chain is shorter. More than 50% of the compound is of short length, so it will not cover both the antithrombin and thrombin, so it will suppress thrombin to a limited ratio. This is the explanation why there is a difference in the action between the two drugs. Okay, this is a brief on the heparin. For clinical purpose, when we compare the difference between heparin and low molecular weight heparin, the low molecular weight heparin offers better big advantages as it is long acting, so it can be given twice or once as the protocol of treatment. It has a good bioavailability, so it has a good predictive effect. It has minimal resistance to heparin. It has a lower incidence of HIT, lower incidence of bleeding, so it's very good. And it has a lower incidence also for HIT. However, the clinical papers say that we don't need lab monitoring for low molecular weight heparin. I want to stress on a point. We don't monitor the coagulation. By this lab monitoring, they mean the coagulation. So I don't need to check the APT-T, for example. But for the clinical purpose, I have to monitor platelet count thoroughly, especially if the patient is exposed to heparin for more than 5 days, in order to pick up the problem, which is really very serious, and it can be life-threatening and limb-threatening, as we will know. So we will discuss HIT. HIT means heparin-induced thrombocytopenia. Thrombocytopenia means decrease in the platelet count, so the definition is very clear. This is reduction in the platelet count after exposure to heparin. This is the definition. HIT, heparin-induced thrombocytopenia, is divided into two major categories. Type 1, which is called HAT, which is heparin-associated thrombocytopenia. Type 2 is HIT. Type 2, it's heparin-induced thrombocytopenia. Take care. HAT means associated. HIT means heparin-induced. Now, the problem comes with the HIT type 2. HIT type 1 HAT, it's a moderate disease. It's reversible even without treatment. So whenever a patient is receiving heparin, after 2 days, the platelet count may show slight decrease, And this occurs in a lots percentage of patients. 1/5 of the patient, 10 to 20% of the patient will suffer from HAT. However, because it's not immune and it's moderate and it will reverse spontaneously, there is no problems. And thanks to God, although it's a big percentage, but it's a mild complication. Thanks to God again, HIT type 2 is a severe form because it's an autoimmune mediated. It develops after 5 to 10 days, and it's the patient here shows severe thrombocytopenia. It occurs, thanks to God, in 1 to 3% of the patients. So, in HIT, what's the platelet count might be? The platelet count might decrease up to 30 to 50% reduction in the number of the platelets. The average will be around 60,000. It will never go down below 20,000. These are classic features of HIT. To revise it again, the platelet count will start to decrease after 5 to 10 days. The reduction will be in the range of 30 to 50% reduction. The average count of the platelets in the range of 60,000, never below 20. Why this occurs? There is activation of the platelets, and we knew from the physiology, activation of the platelets release ADP. ADP is the glue for the platelets. So they start to stick together, making what's called a platelet plug. So the platelet will be consumed. Activation of the platelets, it will not stay platelet per se. It will activate the coagulation cascade. As you know, platelets play a role in the coagulation cascade. So we discussed first the physiology. Now, the pathology is there are a lot formation of platelet plug, white clots. This is formed of heparin, of platelets. Then there are thrombi, which is formed of platelet plus coagulation factors. As a result of consumption of these platelets, the platelet count will go down, and this is the cause of the thrombocytopenia the patient complains of. The thrombotic event is very high. Its incidence is 30 to 80%. So the golden rule in any ICU patient, CBC should be followed if treatment with heparin lasts for more than 5 days. Please, this is a crucial information. Whenever you treat a patient, whether with unfractionated or low molecular weight heparin for more than 5 days, not only treatment, even flush. The patient may be in the ICU, and for flush for the central line or the arterial line, we use even the small dose of heparin may precipitate, as it is immune-based reaction. Here's a quick revision between the two types. Type 1 HAT and type 2 HIT. 1 is mild form, 2 is severe form. Incidence, thanks to God, in order not to forget, the mild is the more occurring. So its incidence is 10 to 20%, while the severe form is only 1 to 3%, thanks to God. Timing in the mild form in type 1, it occurs after 1 to 2 to 3 days only, while the other one, classically, it occurs after 5 to 10 days. The lowest decrease in the platelet count in the first type 1, is 100,000, while the other type, it's mainly in the range of 60, never below 20. This is the lowest figure. Antibody mediated for type 1, no. For type 2, yes, it's IgG related. For the thromboembolic sequelae, it doesn't occur in type 1, but it occurs in type 2, 30 to 80%. So treatment for it will differ greatly, because the first one is mild, non-immune, self-limited, spontaneous remission. It needs no treatment, only observe your patient, the observation by the platelet count and clinical. While the other type, it's very, it has a very aggressive course, as mortality and morbidity increase by 6% per day. Can you imagine how aggressive this complication? So I have to, whenever I discover a patient with HIT, I had to stop it and withdraw it immediately. But the patient still needs anticoagulation. So I have to shift to another anticoagulant, because the pathology, there is activation of the platelets. I have to add antiplatelet drugs. Lastly, I might try plasmapheresis, because it's autoimmune related disease or complication, leading to the formation of a lot of antibodies of the IgG group. This is the part of physiology. Here's the platelet. It's oval in shape normally. It contains granules, alpha and dense granules, which contains the factors which, when released, stimulate coagulation. One of these factors is platelet factor 4. Platelet factor 4, in the presence of heparin, act as a hapten. It stimulates the formation of antibodies. So antibodies will be formed by the beta cells. Then the antibodies will combine with the complex platelet factor and heparin, so that three come together. Who are the three? Platelet factor with heparin and the antibody against the complex. These, the three will affect the platelets, causing its activation. As you see from the diagram, activation of the platelets leads to change in its shape. It becomes swollen. It starts to release its mediators, which stimulate the coagulation cascade. This is the pathophysiology. This complex, it attaches both to the platelets and to the endothelial surface of the blood vessels. The end result is activation of the platelets, which stimulate the coagulation cascade, ending by thrombin generation. Thrombin means thrombus, okay? This pathway of thrombin generation may ultimately lead to thrombus formation and possible thromboembolic sequelae. The antibodies, this information is very important. The antibodies that are formed may persist for weeks to months following heparin administration. Therefore, if a patient develops type 2 HIT and heparin is administered at a later date after heparin exposure within 1 to 3 months, when the circulating antibodies are still there in the blood, platelet level may decrease abruptly within hours. So the presentation of HIT, it may be early. This means the patient will develop the clinical picture and the drop in the platelet count within 24 hours of heparin administration. This is unusual. This occurs if the patient was treated with heparin recently, within maximum 30 to 100 days. The second presentation is a typical one, which occurs after 5 to 10 days after the beginning treatment of heparin. The last one is a very rare one. It's a delayed onset. It occurs several days after heparin stoppage, and this is quite strange. This is the picture presenting the early and the typical types. Here's the patient started about 160,000, and he started heparin treatment. After a few days, the platelet count become 60. It started to decrease within 5 days. The maximum and the platelets is decreasing, and so on, starting from day 5, as you see, the upper point of the graph. The upper point of the graph, around 5 days, it started to decrease. After 5 days, the lowest descent is 60%. Then the patient stopped heparin, so the platelet count started to rise again. After 1 month, the patient received again heparin. The platelet count was 179,000. After 1 day, the platelet count dropped dramatically into 49 after 1 day. So this is the early onset. Why? Because the patient was treated within 1 month by heparin. Okay, this is a patient with HIT. An important information: the patient may have HIT while the platelet count is completely normal. Example: if the patient has a platelet count of 450, after 5 days, the platelet count started to decrease. It became 400, 350, 300, 250. The descent, still the count is completely normal. You cannot say it's thrombocytopenia. It's out of the definition of thrombocytopenia, but it fulfills the criteria of heparin-induced thrombocytopenia. As heparin-induced thrombocytopenia means decrease less, about 30 to 40% decrease from the baseline. So we have to watch carefully the platelet count of the patient for follow-up. Okay? Let's talk about the risk factors, or who are the patients who are liable to get HIT. For the gender, unfortunately, females are more common than male, especially if they are admitted for surgical purposes. So the HIT is very common in surgical work than in medical work. especially after certain operations as cardiac surgery or orthopedic surgery. This is as regards the cause of hospital admission. Whenever the patient is exposed to heparin, this is considered as a risk factor, and you see the previous slide. Type of heparin, unfractionated heparin causes more incidence of HIT, and this is one of the advantage of low molecular weight heparin. It has a lower incidence of both HIT and bleeding. As regards the type of heparin, it's more common in the bovine type. It's 5 to 6 times more common than the porcine type. As regards the duration, as long as the duration increases, the incidence will increase. So,
Prof, 5 minutes more, please.
Okay, so it's the heparin. In case of less than 4 days, it's 0.2%, while more than 4 days, the incidence was 2.6. Clinical manifestation, typically the drop in the platelet count is one criteria. Number 2, evidence of thrombosis, which can occur in the venous side or the arterial side. When it occurs in the venous side, it leads to limb gangrene. Also, there will be a skin manifestation I will mention now. Also, the patient may present with transient global amnesia. For the venous thrombosis, it may affect may cause DVT in the upper extremities or lower extremities. In the upper extremities where the catheters are inserted, it can cause pulmonary embolism in 25% of patients, venous gangrene, or cerebral sinus thrombosis, or adrenal vein thrombosis leading to suprarenal infarction. As if it starts by occlusion of the vein, it will be congested, then secondary, it will go into infarction. On the arterial side, it will cause stroke, myocardial infarction, limb ischemia. So limb ischemia can be due to arterial or venous, mesenteric occlusion, or organ infarction as in the kidney. Skin manifestation is necrosis, especially in fat-rich areas. However, it may affect other areas as the nose or distal extremities. The extremities or the skin show bluish to purple discoloration and hemorrhage and necrosis at site of cannula insertion. Clinically, as we said, lab, there is a score called the scoring system 40s. This is the scoring, and accordingly, when we count as mentioned, it tell us the probability. If it's 0 to 3, it's a low probability. It's 4 to 5, intermediate. 6 to 8, it's high probability. As regards the lab, it's a serotonin release test. This is a specific but a slow test. Although it's sensor specific, but it takes 7 days. So I cannot wait for 7 days to start on a solid ground on scientific base by the lab. So I have to shift the other modality of diagnosis, which is the ELISA, which detects the antibodies. How to treat? 4 main lines of treatment: withdrawal of all heparin preparations, alternative anticoagulant, antiplatelets, plasmapheresis. We have to stop all types of heparin immediately, whether heparin given subcutaneous or heparin infusion or flush, or even heparin coated catheter should be stopped immediately and withdrawn, because even the minimum concentration of the flush can cause a serious complication as it's immune mediated reaction. Then we have to start the alternative anticoagulant as argatropan, bivalirudin, irodine, or antithrombin or anti-factor 10. new oral anticoagulant. This is the examples of the drugs. For the platelets which are activated causing the problem, we can give antiplatelet drugs. Iloprost is a prostaglandin, which causes also in addition vasodilation, or we can give aspirin or clopidogrel. These are the line of modalities. I want to stress lastly on two important knowledge. Although the patient may have severe thrombocytopenia up to 40, maybe it's contraindicated to give these patients platelet concentrate or blood, as it will exacerbate the situation, as it's as if you are giving a fuel. You are supplying the platelets, which will be activated by the antibodies already present in the blood. Don't give warfarin for these patients. After the discharge, patient can take warfarin, provided the platelet count is returned to normal. This is a must. For our case, the choice was argatropan. Thank you.
Thank you very much, Prof. Randa and Barbara, are you here?
Yes, I can hear. Thank you so much, Dr. Badawi. Let me see if we have some questions for you.
Okay.
Hi. Does anyone have some questions for Dr. Badawi, please?
There is some question, I think, is no, I don't think there is any. Is all praising the presentation, and it is wonderful one, and very informative, because the HIT is one of the most difficult topic in heparin and the heparin-induced thrombocytopenia. I don't have really here much question here. So yeah, all yours, Barbara, if you want to ask anything.
How often, Dr. Badawi, do you see this in your ICU? How often, often?
Unfortunately, I see this complication in my mom. I don't work in the ICU, but this is the main reason I insist to teach the people, because it passed a note. Unfortunately, the people there couldn't diagnose it. They thought it was sepsis. Okay.
Oh my goodness, that's awful. Yes, it's that's bad. Well, it was a very, very informative lecture. Very, very thorough. Thank you so much.
You're welcome. Thank you.
Adil,
But you have a question for me? ازيك يا استاذنا اخبارك؟
Good evening to you. Any question for Prof. Makarita? He can answer. He's here ready, and he can answer many questions. Despite we are very late already, you know. So.
Oh, here's there one popped up right now for Dr. Badawi. What is the mechanism of pulmonary embolism in HIT?
It's the state is the condition is a hypercoagulable state. Activation of the platelets that leads to a stimulation of the coagulation cascade. Whether it can occur, the complication, it can occur in any artery, or it may be DVT and propagated. As the thrombosis occurs both in the arterial and venous side.
Thank you, Dr. Badawi.
You're welcome.
Are we at the point to close the session tonight?
I believe we've had all the questions that we can answer. Everyone's done a wonderful job. Thank you so much.
Thank you very much, Barbara from Ohio, and thanks for all wonderful professors and the presentation tonight. Prof. Samir Ansari, Prof. Makarita, Prof. Randa Badawi, and Barbara from Ohio, Prof. Adil Ibrahim from Eminent, and my organizing colleagues, Dr. Hisham and Dr. Walid Aswa, all of you. We are born again today, the Mega Online course. Thank you very much for coming here tonight, and all the best. Thank you.
Thank you. Thank you, everyone.
Thank you, Dr. Randa. Before this is a very short notice.
Thank you, Dr. Saad.
Thank you very much, Prof. Your pleasure.
Thank you.
Thank you very much. We are honored. Thank you.
Thank you.
Good evening. Thanks, Barbara.
Thank you for inviting me. Thank you so much,
Thank
everybody.
you very much, Barbara. We are honored to have you on the line. Thank you.